Welcome. Thank you for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient Family Learning Center at Mass General. Before we get started, I just want to go a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Please note that you are in listen-only mode. Everyone has been muted so we can hear our guest speaker today. If you have any questions for our guest speaker, you may use the chat feature, which is located at the bottom of your screen. We'll have time for in the end. Only Blum Center staff and our guest speaker will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we'd like to ask you to help us complete. Your feedback is important to us as we plan future programs. Okay, so next I am going to introduce you all to today's guest speaker. Joining us today, we have Dr. Ashby Clay Turner. Dr. Turner is from Lexington, Kentucky, and graduated from the University of Kentucky College of Medicine. He completed his stroke training at Mass General and has been on faculty since 2021. His research interests include stroke systems of care and machine learning. In recognition of National Stroke Awareness Month, he joins us today to give a talk on stroke. So please join me in welcoming Dr. Turner.
Thank you very much. I'm going to get my slides pulled up here. That into presentation mode. Excellent. Well, it's a pleasure to be here talking about this important topic. Sorry, I don't know why that happened. It's an important topic here in Stroke Awareness Month. Again, I'm one of the stroke neurologists at MGH, and so this is a topic very near and dear to my heart and what I see day in and day out. And so it's, again, a pleasure to be here and talking to you all about this, and hopefully we can, after the presentation, have a good conversation and answer any questions that you all may have about this topic that you can take back into your own lives. So why do we talk about stroke? Well, let's look at the numbers. So every 40 seconds, someone in the US has a stroke. Slightly more women than men have a stroke each year. 1 in 4 strokes are people who have had a previous stroke. And stroke is currently number 5 cause of death in the US, and it's also in the top 5, even a little bit higher actually, in terms of morbidity, and disability. So while we certainly worry about it as a fatal cause, it can, even in the patients where it doesn't result in death, it can still have significant impairment and alteration of one's quality of life. And it's theorized that 80% of all strokes can be prevented, hence the importance of having this talk here. Over the past few years, we have seen the incidence of stroke in the US go down amongst older patients 75 years or older, but we have seen it go up actually among younger patients who are 49 or younger. So we've been doing a good job with getting awareness out there, intervening with primary, secondary prevention following stroke, or if someone hasn't had one, trying to get ahead of it with working with primary care providers. We're seeing this uptick in patients of younger age groups having strokes for various reasons. But still, even despite our success, for patients 75 and older, it's not time to take our foot off the gas by any means, and we still have a lot of work to do. What is a stroke? It would be important to kind of break this down into 2 categories. There's ischemic stroke, which is where there's a blockage of blood flow. That's what people would classically think of as a stroke, and for good reason. It's about 80% of all strokes are of the ischemic variety. So of typically a blood clot or a blocked blood vessel that impedes blood flow to the brain. This can happen anywhere from the heart all the way up into the small branches inside the brain. Generally speaking, the larger the vessel is that's blocked, the more region of the brain that area supplies, and potentially the larger the stroke, potentially the more devastating the injury. But the clot can occur anywhere from the chest all the way up into the brain. The other variety of stroke is a hemorrhagic stroke or a bleeding stroke. This is less frequent than the ischemic type, but can be certainly equally as important. I mean, hemorrhagic strokes tend to have actually a higher rate of mortality initially, but the patients who survive the initial event often do better than patients who have a clot variety. But there are a lot of nuance to that. Both should be taken seriously. And clinically, it's very difficult to distinguish which type of stroke a patient is having at the onset of symptoms, because they can be identical. And we'll get more into what those symptoms could be. But this is the reason that it could be either of the clot or the bleeding variety is why getting to the hospital quickly is so important, so that we can get the imaging, the CAT scan, that can tell us if it is a bleed or not. And that's really the key testing that needs to be done in order to distinguish which type of stroke it is, because we manage each of them differently, quite differently, actually, as you would probably imagine. So, but when we talk about stroke, technically it's a blanket term that covers both the clot or a bleeding type. I want to distinguish the stroke from a TIA, or a transient ischemic attack. You may have heard this term specifically, or some describe it as a mini stroke. I don't know why it keeps jumping. I'm sorry. A mini stroke or a warning stroke. A TIA is where there's still a blockage of blood flow. So this would fall more under the ischemic division of stroke. But the blockage either breaks up or other vessels compensate to resupply that area of the brain before permanent injury is completed. So before that region of brain is infarcted or killed, the blood flow is restored. And it can initially will present the same way as an ischemic stroke. And the only way you know it's a TIA is because the symptoms then resolve. But for those first few minutes, while the patient is symptomatic and having stroke symptoms, you don't know if it's going to be a full stroke and be irreversible, or if it's going to be a TIA and you'll clear up. So because of that, if anyone will ever have stroke symptoms, again, getting to the hospital as quickly as possible is paramount, so that the treatments, all available treatments are available in those instances. But again, it's the same. It's where there's a clot that forms, area of the brain is still deprived of oxygen and blood flow, so the still stroke symptoms come on. But in these cases, fortunately, blood flow is restored and that area of brain is salvaged. But it still is a medical emergency. And importantly, a TIA, even though it has a better outcome for the initial event, it still increases the risk of future stroke. We take it very seriously, and is still an event that we want to afterwards work up to figure out, as we would with a stroke, what led to that TIA and what we can then do moving forward to prevent the patient from having another TIA, or even more so having a stroke. You know, in terms of what are the stroke symptoms, we use the acronym BFAST. And before we get into the specifics, I want to keep driving home, you know, the importance of acting quickly. We have really two treatment options for an ischemic stroke. One is a medication that's given through the IV, TPA, or there's a newer version, TNK, or tenecteplase. Talk about this more in a minute, but the point is that those medications, the IV medications, have a timeline where the earlier that a patient comes in, the more likely there is of success and a better outcome. But also, we can only administer that medication for up to 4.5 hours from when a patient was last well. So in other words, without symptoms. So we're very much on the clock by the time the patient arrives. But it's important to acknowledge that that clock is started even before the patient gets into the hospital. And often the patients who have strokes arrive already too late for that treatment options to be available to them. So because they thought that the symptoms would go away, or it wasn't recognized, or various reasons, that could lead to delay. But by not getting into the hospital quickly, can limit what options a patient has as far as rescue treatments, and can negatively impact their outcome from that stroke event. The stroke symptoms are, it's going to be, the key thing with a stroke is it's going to be sudden. It's going to be a sudden onset could be a variety of different symptoms. So it's not going to be something where you're like, well, I have, a little numbness in my toes, and it's over the last, months to years, it's crept up, and is now up to my knees, right? That wouldn't be a stroke. This is going to be something where from 1 minute you're feeling at your baseline, and then the next minute these new symptoms have suddenly developed. And we use the acronym BFAST, which is expanding upon the prior FAST acronym, to include and to encompass more accurately the range of stroke symptoms. So the B is for balance. So this could be a loss of balance or dizziness. And classically, for a stroke, that feeling of dizziness would be a true vertigo. So a sensation of movement, in the absence of actually moving. So it could be that you feel like you're spinning around or rocking, or you feel like the room itself is spinning around or rocking. The E is for eyes, and this would include either a loss of vision. So it could be one eye just kind of going graying or blacking out, or part of the vision in one eye graying or blocking out, or it could be part of a visual field losing. Could be half of your vision, or a segment of your visual field involving both eyes. But a sudden loss of vision is could be a sign of a stroke. This is different from just having some blurry vision that, I mean, I wear glasses. If I take them off, it's, I sense that my vision's, not what it used to be. And it's, as with many of us, it's gradually gotten worse, over the years. This wouldn't be from a stroke. A stroke symptoms would be, again, a sudden change in vision. A graying out or blacking out of vision would be the classic symptom. The F, and this is the FAST acronym, is the same as what it has been for decades. So you're perhaps more familiar with this portion of the acronym. But the F stands for face, which is facial drooping or uneven smile. So one side of the face, often could be involving the mouth, but it could involve the eye a little bit, would be droopy. And the A is for arm, which could mean, arm, but arm or leg, where if you were to hold your arms up, one would drift down. Or same with the leg. You sort of try to lift your legs, if you were laying or sitting down and lift your legs up, one may drift down. But it would be, classically, it would be asymmetric, sudden onset of weakness. The S is for speech, and this could be either slurred speech, it could be difficulty speaking, getting your words out, or thinking of the right word. It could also include understanding what other people are saying to you, or more broadly, just kind of what may seem like confusion with a patient. And this would, again, be a sudden change that a patient may experience. And then the T, which would be the most important of the portions of the acronym, is time. And again, for if you were to experience any of these symptoms or even others that would be concerning, call 911 immediately and get to the hospital. Again, because the faster you were to arrive at the hospital, the more options we have on the table as far as treatments, and the better chance you have of having a good outcome. This is an older picture here of a depiction of these symptoms better. This is again just the fast portion. We've added in the B before, so it's the balance, and then the eyes, vision loss. But this would be face being droopy. You can see this cartoon character here has the droopy right side of his face. The arms, as I mentioned, you hold up both arms, and what would be concerning is if one would drift down. Speech changes, is there any change in someone's speech? If you were to be with somebody and you're worried about it, ask them questions, ask them to repeat something that you would say. And then of course T is call 911 right away. Stroke treatments. This is going to be really important, and kind of what I've alluded to throughout the talk thus far. Again, these are CAT scan or CT scan, same thing, images, which is what we would get on any patient who came in with stroke-like symptoms. And again, this is to really the key thing here is to distinguish whether this is a bleed, as the picture on the right with the pink outline, or if this is it could be more of an ischemic stroke, which if a patient were to get in quick enough who is having a stroke, the initial CAT scan may be normal in an ischemic stroke. That's really what we would hope for, because that would be a sign to us that while there may be a clot, it has not yet resulted in, or potentially has not yet resulted in injury to that brain tissue. And that's what we're seeing here with this CT image here on the far left side of the screen. This is a normal looking CAT scan, and this is an X-ray. CAT scan is an X-ray derived image that is very quick, very rapid to obtain. Any hospital would have this capability, and so that's why we always encourage patients who, if they're having stroke-like symptoms, to get to the nearest facility, the nearest hospital, even if that may not be the hospital where they receive the majority of their care. I would encourage, if you ever were to be worried about stroke symptoms in yourself or someone else, just get to the nearest facility. Transfers and outside consultations can always occur later on, but you want to make sure that you get in so that you can get evaluated, get CAT scan as quickly as possible to determine treatment eligibility. So again, this is what we would get in every patient who came in with stroke symptoms. This is a normal scan. This is what we always hope to see, because that would maybe a sign that we're early enough in the process that any or all treatments may be on the table. This is a CAT scan of a patient who has some early stroke findings. So we can see here on the right side of the image, if you're just kind of comparing one side to the other, this is the ventricle, a large fluid sac inside the brain. We see here on the opposite side, it looks a little bit more compressed. And then we're also seeing some early signs where it's darker here on the impacted side compared to the contralateral side that looks quite normal. So this is a sign, as a stroke neurologist, if I saw this scan, I would be worried that this patient's stroke over here, for one, looks to be quite large, but also we're seeing changes on the CAT scan. I'd worry that maybe this stroke is on the older side, more several hours, perhaps even days old, compared to if a patient who may even have the same symptoms had a scan like our normal one here on the left side. And the ischemic stroke can be differentiated via CAT scan from a hemorrhagic stroke, where new blood can show up very bright, very often quite distinguishable on a CT scan. So here we see some pockets of blood here in this patient's uh, 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 hemisphere that would be concerning, that are indicative of a hemorrhage. So, let's talk about the evolution of stroke care as we, consider the topic of treatments. From the 50s through the 80s, there was a lot of research, and a lot of it was done, at Mass General, and Dr. Miller Fisher was behind a lot of those Paramount publications. But there weren't any treatments that for an acute stroke. So, right at symptom onset to potentially reverse the clot, reverse the injury, really until 1995. So quite, relatively recently, it wasn't until relatively recently did we have any options for stroke care. And this 1995 big landscape or a Paramount trial came out that showed the efficacy of using TPA, or tissue plasminogen activator. It's an IV medication within the first few hours from the patient's last known well. So first few hours of the stroke. And patients who received the medication quickly had a better outcome than patients who did not receive the medication. Over the next 20 years, that the inclusion criteria, so the number of patients eligible for this treatment, has grown somewhat, but we still have some key restrictions there. But notably, the timeline is the main one, and often the main limiting factor for acute stroke care. So for TPA or other IV, what we call thrombolytic or clot busting medications, the time window is only 4.5 hours from last known well. So again, getting into the hospital very quickly is key to even having this as an option of treatment. In 2015, we made a huge second step of endovascular therapy. So this is where, unlike the IV medications that are given through the IV and work systemically, this is a mechanical extraction of the clot using a minimally invasive catheter. So we can see in the little thumbnail picture here, this is a blood vessel. This would be the carotid artery coming up into the brain here, branching off into a large middle cerebral artery. We can see a large clot here sitting in this vessel that would have been blocking blood flow downstream to all branches and therefore all regions of the brain, on this side of that patient's brain hemisphere. We can see there's a very small catheter that can go all the way up in the vessel, and they've already deployed this clot retrieval device that has gone through the clot and is expanded out to grip it. And then the next step would be that they would try to pull this catheter back out and with the clot still attached, therefore physically restoring blood flow to that region of the brain. Importantly, patients who have strokes may be eligible, depending on how quickly they arrive, for one or both of these treatments. But the longer the stroke has been ongoing prior to arrival, the less likely either of these would be options. Currently, our guidelines support offering the endovascular therapy up to 24 hours from last known well. So it can often be, so it is more inclusive than the 4.5 hours for the IV medication. But the eligibility for endovascular treatment is a little bit tighter. We have to have a clot that we can see in a vessel that we can get to. And so that would not include all types of ischemic strokes. Whereas the thrombolytic medication, while it may be more restrictive in terms of time, it does have a broader inclusion criteria, generally speaking, as far as availability or patient eligibility. But both can be important, and in many instances, both can be options. And with all this continued evolution, it makes us wonder what things will look like, 20 years from the last development, and what we'll be doing. And that's what many of us are working on from a research standpoint. So stay tuned. It's a rapidly evolving field. As you can see, it's a relatively new field as far as acute stroke goes. But as we led off by talking about the numbers and the top 5 leading cause of death, the top 5 leading cause of morbidity and mortality, stroke is a very a topic of very high interest in the medical community, as well as the community as a whole. I've mentioned here before, the TPA, or the IV clot busting medication, tissue plasminogen activator. It's a medication that we give that can help break up the clot. So it must be given within 4.5 hours of stroke onset. But even within this time frame, the faster the better. So patients who get it at 1 hour do better than patients who get it at 4 hours, even though they both technically meet the eligibility umbrella. So still, important to get in as quickly as possible. Really, as I've also alluded to, we have 2 of these medications available: Alteplase, which is the same as the TPA, or Tenecteplase, which is a slight variant. And it depends on which hospital, what the hospital you go to uses. Both are thought to be essentially equivalent. So it's not that one, as we know right now, not one is really better than the other. At Mass General, we use Tenecteplase. That is the newer one, but it's primarily the favorability of using this over the traditional Alteplase, also known as TPA, is that it can be given as one single dose, whereas the TPA does have to be an infusion over an hour. So it just, in terms of operations, it's a little bit easier for us to give it, which is why one of the main reasons why we liked it and chose to switch to it. But both are effective, and if you go to a facility that offers TPA, that's you would want to get that if it was available to you. And then we've mentioned the thrombectomy. So this is to physically remove the clot. And so this is based on the presentation. Thrombectomies can be performed up to 24 hours after symptom onset, as we mentioned. So a little bit of a longer inclusion window. But again, we have to be able to identify the clot, and also feel that we can go and physically reach the clot. So a clot that was maybe in one of these smaller branches further out inside the brain, while it still could be causing stroke symptoms, if we can't get to it, then this would not be an option. But for the clots where we can reach, this has been really a groundbreaking and game-changing development in the stroke world. But again, the sooner it's performed, the greater chance of recovery. So a patient who gets it at hour 1 or 2 is going to do better, generally speaking, than the patient who gets it at hour 22. And so time is still of the essence. Here's included this. I thought it was a interesting picture. This is what is the view of the provider, who would be the surgeon who would be performing the thrombectomy. So this is an angiogram, also of X-ray variety. And we're looking at the patient face to face here. You can see a faint outline of the skull. And then this is the carotid artery coming up snaking around into the brain. Then it's branching off into its main 2 branches. But we can see here that there looks like you can imagine a sudden cutoff of this relatively large vessel here. It should go up and supply, have branches that go and supply this region of the brain, this wedge. But because of this blockage, we're seeing an absence of flow here, in this large region of the brain, which would, in this case, I would presume, likely leading to a patient having stroke symptoms for areas supplied by this vessel. And then I would also assume by the fact that they're obtaining this image that they're optimistic that this clot could be retrieved and this area could be reperfused or blood flow restored to try to salvage much, if not all, of this region of brain. So this would be the view that those providers would be looking at as they maneuver their catheters through the vessel to reach this clot and then hopefully then be able to extract it back down the vessel. Again, this is a minimally invasive procedure. They'll go in through the often through the femoral artery in the groin, go up through the aorta, then navigate their way into the brain to retrieve this. So it's not an open surgical procedure. It's one they can perform quite rapidly, and at the end just get a Band-Aid placed over the incision site. This is another view of the same vessel here, and you can see that now the blood flow has been restored through this vessel, and we're seeing come up, and we're seeing more vessels filling. This is just one cut. This is a dynamic view. So if we were to continue to watch this, as a video, we'd likely see the remainder of these vessels filling in this area. But the key point of the shot here was to see that now that vessel that was on our previous view cut off has now been restored, and we're seeing the early filling of these branches. So again, a successful thrombectomy in this case, it appears. For hemorrhagic strokes, we treat quite differently. You would imagine the aggressive IV clot busting medication, that we would give to someone with an ischemic stroke would be actually detrimental to a patient who is already having a bleed, because the TPA, or the clot busting medication, is designed to quickly break up a clot and prevent clotting. Whereas with a hemorrhagic stroke, we would actually want that clotting to occur to block off the leakage, the leaky vessel that is causing the hemorrhage to occur. So that's why it's key that we differentiate what type of stroke a patient may be having initially, because the treatments are quite opposite. For hemorrhagic stroke, main thing we're going to try to do is, one, control the blood pressure. That often the bleeds are at least partially attributable to high blood pressure. So in the moment, we would want to bring the blood pressure down to decrease the strain on the vessel and therefore the ongoing bleeding. We want to reverse any blood thinning medications if the patient were on them. They're on Eliquis or warfarin, or any other true blood thinner. We want to reverse those medications, as they could be contributing to ongoing bleeding. And then in certain cases, neurosurgical intervention may be necessary, going in and trying to extract some of the bleeding, some of the blood and the mass effect there, to decompress or take pressure off of areas of the brain that may be at risk of further injury. So, we a very different pathway of treatments, of strategy, that we would pursue if we were to see a bleed on the CAT scan, in contrast to an ischemic stroke. So what are the risk factors of stroke? Again, we started by saying that roughly 80% of strokes were preventable. So we think about risk factors in two categories. There's the modifiable, and then there's non-modifiable. So the things that we can control, and then the things that we cannot control. Our modifiable risk factors, starting with high blood pressure or hypertension. And this is, the number one contributor of stroke, both ischemic and hemorrhagic. This is going to be a major contributor. So working on blood pressure is something that I often will talk about in essentially every visit I have with patients. Atrial fibrillation, or AFib, is a major risk factor of stroke. AFib is a heart arrhythmia that can increase risk of clot formation in the heart. And those clots, when they leave the heart, if they were to go to the brain, could contribute to an ischemic stroke. And so AFib is a major stroke risk factor that we would want to identify should a patient have that. Hyperlipidemia or high cholesterol, atherosclerosis, which is plaque buildup in the blood vessels, can be due to some blood pressure and cholesterol, but we do look at it as a risk factor as itself, and diabetes can also contribute to that, atherosclerosis that is, but is also a risk factor that we want to optimize. Smoking or vaping, excessive alcohol intake, drug abuse, lack of exercise, and then diet and obesity. So these are the main modifiable risk factors that we want to work on and optimize to reduce someone's risk of having preferably a first stroke, but certainly an additional one if they've already been a victim of such. Non-modifiable risk factors would include age. So we know the stroke risk is greatest in patients who are over 65. Again, we've seen, as I mentioned at the beginning, an increase in prevalence of stroke in patients younger than that. But still, the absolute numbers are much less than those of patients who are over 65. Family history or genetics, again, non-modifiable risk factor, at least currently. And then sex, that slightly more females have strokes than males do. But again, high blood pressure, the number one leading cause of stroke. So how can we prevent stroke? So stroke is prevented by, this is one way of looking at it. This is from the American Heart Association of Life's Essential 8. So it includes a healthy diet, physical activity. So the American Heart Association, they recommend targeting 150 minutes a week of exercise, 150. And that could include walking in the neighborhood. It doesn't have to be something strenuous. It could be, going for a walk, bike ride, hiking, pickleball, swimming, weights, just some sort of physical activity. 150 minutes may sound like a lot, but that can be fractioned out to 30 minutes a day, 5 days a week. And so kind of targeting that as a minimum has been shown to decrease the chance of stroke as well as heart attack, and even, several other things, including dementia even. Avoiding smoking or vaping, healthy sleep. So if you, particularly, if you were to have sleep apnea, being compliant with your CPAP or BiPAP at night, improves the quality there and reduces chance of stroke. Weight management, controlling cholesterol either through diet and or medications, managing blood sugar if you have diabetes, and then managing blood pressure. As we mentioned, with hypertension being the number one contributor of stroke risk. So kind of going through some of these in a little bit more detail, what is a healthy diet? The American Heart Association really recommends there are two that have been shown to reduce the risk of stroke. First is the DASH diet, also recommended by many cardiologists. So it's a low salt diet with featuring predominantly fresh fruits, fresh vegetables, whole grains, fat-free or low-fat dairy, fish, poultry, so lean proteins, predominantly beans, nuts and seeds, and then vegetable oils, limiting fatty meats, full fat dairy, sugar, sweetened beverages, desserts, and then salt. Similar but with some differences would be the Mediterranean diet. It's one that's also been widely studied and shown to have favorability as far as stroke prevention. Many things are similar to the DASH diet, predominantly fresh fruits, fresh vegetables, again, whole grains, beans and nuts, more extra virgin olive oil as opposed to the vegetable oils, and then lean proteins, predominantly fish. So again, either of these would be good, but you can see a lot of the same differences here, and then and also noting they avoid many of the same things as well. But you'd be well served with either of these two. These are slightly busier slide, but this gets into some of the more specifics of the blood pressure. So, 120 over 80, we certainly want it to be less than 130 over 80 would be, generally our goal. Atrial fibrillation, blood sugar. So if you do have diabetes, certainly you want to check your blood sugar regularly, and, we're targeting a number of less than 100. Is your BMI or body mass index greater than 25? If not, then that is something to work towards. We mentioned the diet already, high in saturated trans fats, sweetened beverages, salt, excess calories, all contributing to targeting a healthy diet. A blood cholesterol, a total of greater than 150. And we'll often look at just the LDL, or focus mainly on the LDL or the bad cholesterol, wanting that to be less than 100, or more preferably less than 70. Have you been diagnosed with diabetes, as being a risk factor? And if so, we want to get that sugar down less than 100. Again, the 150 minutes a week, obtaining that is a goal. Do you have any personal family history? This would be a non-modifiable risk factor, but one to acknowledge, if that was the case. And if you do have a strong personal or family history of stroke, TIA, or heart attack, managing the modifiable risk factors, or these things that we can control, are even more significance. And then, do you smoke or vape? So obviously having, many of these be falling in the no category would be indicative of a lower risk of stroke. And for areas where you may find or may believe that you fall, slightly out of, or would answer yes to, or may not be quite at goal, this would help identify things to work on, and things to change and try to optimize to reduce the stroke risk, either of a first stroke or certainly of a subsequent one. So again, time is brain. This is, I've emphasized this throughout, that getting to the hospital as quickly as possible is most important. One, to increase the options available as far as treatments go, but also to improve your chance of a better outcome, even if the treatments are administered. And the reason for this is that you lose 1.9 million neurons every minute during a stroke. So every minute counts, and getting in quickly cannot be stressed enough. So remember, be fast, balance, eyes, face, arms or legs, speech, and then time, getting in as quickly as possible, and recognizing these symptoms as early as possible, either in yourself or in someone else, and then calling 911 to get into the hospital as quickly as possible. I want to thank you very much. We'll now pivot to questions or clarifications of any of that I've talked about here, and I look forward to hearing your thoughts and helping answer any questions that you may have.
Thank you, Dr. Turner. We're now at the end of this session. If you have any questions for Dr. Turner, feel free to enter them in the chat. We have a question regarding genes. Are there any particular genes that have been identified to contribute to strokes? If so, can people with these particular type of genes do something to lower their risk?
Yeah, that's a great question. So predominantly now, as far as like genetic testing and stroke goes, it's a major topic of interest. Many are working on that and are looking at that. Right now, there aren't really ones for, broadly speaking, of stroke that we would just test routinely. But we would look for genes that could be enhancing some of the risk factors. So, for example, a patient who has high cholesterol, and despite efforts with dietary changes, with medication changes, the cholesterol still remains, significantly elevated. Then there could be genes that could be contributing to causing that elevation, and something that could be tested for, or some with blood pressure, as well, and some other more clotting disorders would be another good example. So if you were some patients who come in who have strokes may also have a history of previous clots, deep vein thromboses or clots elsewhere in the body that may be indicative of a genetic clotting disorder, particularly if there was a family history. And that would be something we would certainly test for. So to answer the question, it wouldn't, we mainly would do testing to look for, to further investigate the certain risk factors, but not as much as looking at stroke in general, at least not at this time.
Thank you. And it seems like AI has become a very popular topic these days, artificial intelligence. Are there any studies being done that you're aware of on the role of AI in detecting stroke before it can happen?
Yeah, that's a great question. For detecting stroke before it happens, yes, there are like and has been a lot of interest in building models to predict one stroke risk and there have been people have looked at different markers to indicate an ongoing active stroke. It becomes a little bit challenging in the moment because one of our main barriers, as I mentioned, is the patient themselves identifying the stroke and getting into the hospital quickly enough. So the challenge with that would be finding a solution that could help the patient when they're out in the field, to use the medical terminology, or at home, or wherever they may be when their symptoms are first recognized. And so the solution would have to be one, at least to detect a stroke as it was ongoing, one that could be implemented by someone at home. And really just even using the acronym Be Fast has been shown to by itself to be quite sensitive at detecting stroke symptoms when they're on when they're in onset. And so using an AI to assist with that could be potentially helpful, but again, the implementation would be the question. Many of us have also looked at using AI to help with and navigate stroke workup. And that's one area where there's been a lot of attention and use of AI. I didn't get into it much in the talk, but one of we kind of look at stroke as you can look at it as like 2 or 3 phases. There's the acute phase, which is mainly what I was talking about here, where we have the thrombolytics, the IV medications, or the thrombectomy. And then there's like the subacute phase where, often the patients are in the hospital or in the first few days to weeks after they may have had their stroke or TIA. And a lot of the emphasis there and the goal of the provider is to try to work up why that stroke happened. Because identifying the specific cause or the etiology, as we describe it, is important because we manage each of the causes differently as far as ongoing prevention. And then the third phase would be the chronic phase. So like after you've identified, patients come in, the acute phase is for treatment. The subacute phase is mostly for workup and starting the prevention phase, and the chronic is really focusing on prevention and optimizing the risk factors. And in the subacute phase, there's been a lot of interest in AI, and I worked on this as much as well as others, of using AI to help us try to figure out what happened, because it can be a very complex puzzle. You're thinking about all of these things that can lead to someone's risk for stroke, and I covered many of the main ones, the most common ones, but there's a whole plethora of even more rare and unusual causes of stroke, including some rare genetic causes that we may look into in certain cases. But piecing all of that together to figure out what caused a stroke in an individual patient requires a lot of expertise and experience. And the reality is there are not a ton of stroke specialists in the US, much less the world. And so utilizing AI to help us put all of that data together, that right now we're having to rely on our own expertise and cumbersome efforts to decipher, has a lot of promise, and one that many of us are very excited about.
Thank you. We have a question regarding risk factors. Do we know why women are at slightly increased risk for stroke?
Yeah, that's a great question. I think the one of the easy answers or convenient answers is that the life expectancy is a little bit longer for women, and so since age is a risk factor, by living longer, you would have more time in that over 65 age range, and so that's certainly one of the thoughts. There is, kind of looking at it too, there it can be slight higher incidence of, in some subgroup populations of like higher cholesterol or blood pressure in women. So there can be some of those that can contribute additionally, on top of increased age. And then there's some thoughts about frequency of going to provider and compliance of medications that does differ sex by gender, but it's something that's certainly of interest, despite there being some theories, but there are some key risk factor differences that we've been able to identify.
Thank you. You briefly touched upon the DASH and Mediterranean diet. Where can one go online to learn more about them?
Sure. I'd say, the American Heart Association, and then they have a subdivision, the American Stroke Association, is a fantastic resource. And they have a quite robust website with additional materials, videos, education materials, and many of us use those as providers, but they're certainly geared towards the general public as well. So I would recommend doing that. There are some other, many, I think through MGH we have some resources, and Cleveland Clinic, some of the Mayo, some of the larger medical institutions also have resources. The American Heart Association, though, is one that's quite well respected, and one that we rely on as providers, because they're also the entity that formulates our guidelines that we use for practice patterns, for secondary prevention goals. So, for example, the blood pressure goal of less than 130 over 80, and the LDL goal that we target of less than 70. Those are they come from the literature that we all read, but are cemented in guidelines that are authored by the American Heart Association. So I would recommend that as a resource for on the diet, as well as any of the other risk factors that I've discussed.
Thank you. And for those who are interested in Life's Essential 8 that Dr. Turner had covered earlier on, I had provided the link to that in the chat, as well as the link to the Blum Center website for anyone interested in viewing the recording.
Thank you.
So while we wait to see if there are any additional questions, are there any final thoughts you'd like to share with the audience?
I'd say that stroke is a complex thing, and it's one where the BFAST acronym encompasses a lot of the symptoms, a lot of the more common stroke syndromes, as we would put it. But stroke can have other it's a wide range of possibilities, because depending on where the clot is or where the bleed is, it could be anywhere in the brain. And so any of our functions could be theoretically impacted, if that area of the brain were, insulted by the clot or by the bleed. And so I think that the BFAST acronym is excellent, certainly one to be familiar with, keep in mind. But with stroke, if it was a sudden change, and you notice in yourself or in someone else, stroke would still be a possibility. And I just recommend being mindful of these symptoms, and if you're in doubt, better safe than sorry, and just go in, get evaluated, get assessed, and see. And just because you're having symptoms like that, I didn't mention it too, but the stroke is what we always worry about with these types of symptoms, the BFAST symptoms and others. But there are many things that can mimic stroke that are not stroke. So that's why getting in and getting evaluated is so important, because the experts will try to differentiate whether we think that it is truly an ischemic event, or whether it can be one of the many other processes that can cause stroke-like symptoms, but not due to either a clot or to a bleed.
Yeah.
Of course.
I don't see any additional questions in the chat, so I think it'd be fine to end a few minutes early. Dr. Turner, thank you so much for spending the hour with us. This is extremely helpful.
My pleasure. And it's a topic I love talking about, and thank you all for inviting me, and it's been a pleasure to share these my passion with you all.
Thank you. And for everyone who's joined, thank you so much. As I had mentioned, today's session is recorded. If you're interested in viewing the recording, they'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Thank you so much, everyone. Have a lovely rest of the day.
Thank you.